So somebody asked me a question, sir, you have done MD General Medicine. How will you teach all 19 subjects? I told them simple thing. The student preparing for entrance is one student only. And he is preparing for 19 subjects, no? So when a student is preparing for 19 subjects, what is wrong with a teacher from teaching 19 subjects? Except he can be very boring and monotonous. Don't worry. We have some excellent ophthalmologists as teachers. We will call them for 1 or 2 days as guest lecture to cover about some 10 to 15 topics in the end part. But in the beginning, these long crucial topics, no, you give to a proper consultant, he will go into his life of experiences and topic will never end. What we need is, we need to close the topic. This is the end point of the topic, right? But visual field defects, I mean, the visual pathway is our domain of neurology. So that's the reason, no way I can let any other teacher to do that. So, now doctor. To understand the visual pathway problems, we need to know our eyes are watching, optic nerve is carrying, and it is merging at optic chiasma, and from there we have a path all the way until the brain. So, if you know what is the long path, you can be able to answer any question which comes. But anyway, for a quick review, first let me pay a due respect to the tract. So this is the most important illustration. We have a temporal field, we have a nasal field in the retina. So the eye rays fall on that, carried from retina by the optic nerve, which meets at optic chiasma. Then from there it goes to lateral geniculate body, its next station, and that is called optic tract. Then from the lateral geniculate body it will be traveling towards the occipital pole, and during that time it will be forming what are called optic radiations. So there can be any compression at this level. So doctor, with that, let us make the start. What will happen at each level? Now, there is a problem in the optic nerve. What will happen? Complete blindness will be there. It is carrying from the retina until optic chiasma, it is carrying both nasal temporal fibers of the same eye. So that eye's entire vision is gone. So that is the reason if you throw light, the direct light reflects. That means the pupil won't constrict because it is not knowing that light is falling on it. Then there is no carrying forward of that light perception to the other eye. Hence even consensual light reflex will also be absent. That means even the other pupil also won't constrict. Because for the consensual light reflex also, what is from where should the stimulus should start? From this eye only, which is diseased. So that's the reason both direct reflex ipsilateral, consensual reflex which is there on the contralateral side, both of them will be abolished if the optic nerve is having a pathology, is what need to be remembered. Now, we have two kinds of reflexes. One is called near reflex. What is meant by near reflex? If you are reading in the reading room, you are looking towards the book, you are looking at somebody going. So your pupil is constricting, dilating, constricting, dilating. So who will tell your pupil to basically constrict when you are looking very nearer to the print of the book. When you look towards the book very closely, then your both eyes are converging. When they are converging, the reflex will begin, which in turn reflexly will cause pupillary constriction. So that does not require this light sense. What is that reflex called? Near reflex. When I throw light, your pupils constrict. That is called light reflex. So light reflex will be abolished, but near reflex is not abolished if the optic nerve is damaged. You agree with me? Because for near reflex, where is the afferent beginning from? Not retina. The medial rectus, which is converging the eyes when you are reading, is initiating that. And that in turn reflexly is causing Edinger-Westphal nucleus, oculomotor nerve, and then pupillary constriction. That is not affected if optic nerve is damaged or any problem happens. Now, what are the causes where optic nerve can get affected? Optic atrophy, optic neuritis, anything can lead to that. Now, doctor, how is this light reflex basically is mediated? It's very important to understand. So, whenever you are throwing the light is falling on the retina. The optic nerve is carrying it. It reaches the optic chiasma. From there the fibers are reaching midbrain. And in the midbrain you have a pretectal area. From there the fibers will go to both ipsilateral and contralateral Edinger-Westphal nucleus. And from the Edinger-Westphal nucleus the fibers will be carried by the oculomotor. It reaches what is called a ciliary ganglion, and ultimately it will reach the sphincter pupillae and lead to pupillary constriction. Then when you are throwing the light into this eye, why should other eye pupil should constrict? Because when you throw the light, that light perception will reach the pretectal nucleus. From pretectal it will not only go to ipsilateral Edinger-Westphal, even to contralateral Edinger-Westphal. Hence the other eye pupil also will constrict if you throw the light in one eye. Agreed, doctor? Where is the decussation occurring? At the level between pretectal nucleus and Edinger-Westphal, the fibers will go to both ipsilateral Edinger-Westphal and contralateral Edinger-Westphal also. Hence consensual reflex is there. I know you all know this, but I am habituated to assume students don't know anything. They are just newborn is a kind of a feeling I need to start teaching them. So apologize my obsessive emphasis. Now doctor, next comes. ये optic nerve जो है, इसका two parts are there. Proximal part is there. Then you have got a you have got a proximal part and a distal part, but let us not go into that proximal part. Nobody will ask in the exam. Now, after optic nerve, who is involved? Chiasma. Optic chiasma is involved. Chiasma is peculiar. Why? At the level of the chiasma, there is a crossing over. Crossing over. But who is crossing? Yeah. Is it clear? Voice is okay? Okay. As rightly suggested by Nina, first let us discuss pathway and then go to these lesions. Okay. So where is the pathway? Pathway aa jao. So we have the pathway much more clearly reviewed at one of these slides. 1 minute. Yes. First, let us go through the pathway and then we will come back. When the light is thrown in one eye, both the pupils constrict. Already we said it is called direct and consensual reflex. How is this happening? The light perception is initiated by rods and cones in the retina. So where are we now? We are at the level of the retina. It has a nasal, temporal, two things. So here the light perception is perceived. Now these fibers will typically be passing from the retina to the pretectal nucleus. You have no pretectal nucleus in the midbrain. To that point they will pass. How will they travel? They travel through the optic nerve. Now once they reach optic chiasma, they undergo decussation. But who will undergo decussation? The fibers which are coming from the nasal retina will decussate to the contralateral side and go to the opposite side, the lateral geniculate body. Okay? So the nasal retinal fibers will decussate and they travel along the opposite side optic tract and it will ultimately reach the opposite side pretectal nucleus. Whereas the fibers which are coming from temporal retina, chup chop, same side they will travel. Okay? So they travel along the optic nerve to the optic chiasma and the temporal retinal fibers will go to the same side pretectal nucleus. Then at the level of the pretectal nucleus, you have internuncial fibers. What will they do? They basically connect the pretectal nucleus with the Edinger-Westphal nucleus. Where is pretectal nucleus? This is pretectal nucleus. The internuncial fibers will connect pretectal with the Edinger-Westphal. But while connecting, they will connect the both sides Edinger-Westphal. Agree with me? So that is the reason we have both a direct and also consensual light reflex. When you throw light in one side, it reaches same side Edinger-Westphal and opposite side Edinger-Westphal also. Then what will happen from Edinger-Westphal? Edinger-Westphal, from the Edinger-Westphal nucleus in the midbrain, parasympathetic fibers will start. How will they travel? They travel from Edinger-Westphal nucleus to ciliary ganglion. Let us see that. Where is ciliary ganglion? See, this is the Edinger-Westphal nucleus. With the third cranial nerve, they reach the ciliary ganglion. From ciliary ganglion, postganglion fibers will go and reach the sphincter pupillae, and pupil will constrict. So, doctor, what will happen to the preganglionic fibers? How are they basically carried? You have a narrow to inferior oblique, one of the branches of the oculomotor. With them these fibers will travel. Which fibers? The fibers which are going to the sphincter pupillae, they travel along with that. And they reach the ciliary ganglion, and from ciliary ganglion, the postganglionic fibers will pass through short ciliary nerves and they go and innervate the sphincter pupillae. Why is this important to be remembered? Why very specific that along with the narrow to inferior oblique they are carried? Because if diabetes, hypertension like conditions lead to ischemic necrosis to the oculomotor nerve, only the fibers which go to the extraocular muscles get affected without affecting the fibers going to the ciliary ganglion and sphincter pupillae. Hence, pupil won't be affected in oculomotor palsies caused by medical conditions like diabetes and hypertension. Whereas if a partial communicating artery aneurysm like a surgical cause is compressing oculomotor nerve, it will affect both fibers going to the extraocular muscles and also the fibers going to the ciliary ganglion to reach the sphincter pupillae. So pupil will be involved in oculomotor nerve lesions due to the surgical causes and spared in the oculomotor nerve lesions due to the medical causes like diabetes and hypertension. So that is the preganglionic and postganglionic story. You understood now? So who is decussating? Nasal fibers are decussating, temporal fibers are passing ipsilateral. Okay, doctor? Now, one more thing we need to understand is, this is the light reflex. Then comes near reflex. What is the meaning of near reflex? Whenever you look towards a near object, there is a convergence reflex. What is the meaning of convergence? Whenever you look towards a near object, there is a contraction of the pupil when both eyes are converging. Then there is an accommodation reflex. What is that? Typically, whenever you are looking towards a near print, then along with the accommodation, where there is a change in the curvature of the lens, there is a contraction of pupil, which is called accommodation reflex. So these are the two important reflexes. Now we will go back to our original story. Where are we? We finished which one already? Optic nerve is over. Now we are with optic chiasma. Now tell me, doctor. In optic chiasma, suppose if there is a compression directly in the center of the optic chiasma, who get affected? Nasal fibers which are decussating get affected. If there is a compression coming from the sidewise, who is getting affected? The temporal fibers get affected. Simple. If you understand this, you understood everything. Now, doctor, central lesions of the optic chiasma, what will it lead to? The central lesions of the optic chiasma will lead to like pituitary adenoma, which is compressing the central part. They typically lead to bitemporal hemianopia, and that also lead to optic atrophy. So both the things typically happen in case of the central lesions. Now, what are the various causes for the central lesions? Any pituitary gland tumor, or a craniopharyngioma, or a suprasellar meningioma, any of them. If laterally, if there is any compressive lesion, which is compressing the optic chiasma, there will be binasal hemianopia, right? And there is an optic atrophy associated. So when will this happen? Anything that is distending the third ventricle will lead to a lateral compression of the optic chiasma. Now comes optic tract. Where is optic tract? Is from the chiasma until lateral geniculate body. In this, who are there? What are the fibers carried? Same side temporal fibers and opposite side ka nasal fibers. So because of a compression on the optic tract, the lesion is called incongruous homonymous hemianopia, is what you typically have if there is any lesion of optic tract. Then there is an optic atrophy as usual, and in addition, those conditions which are compressing the optic tract will also lead to, because they are at the level of the midbrain, hence third cranial nerve also is paralyzed and the descending corticospinal tract is affected, hence there will also be development of hemiplegia. So often the optic tract lesions are associated with contralateral third nerve and ipsilateral hemiplegic lesion as associated findings, in addition to incongruous homonymous hemianopia is what need to be remembered. Now let us see how a incongruous homonymous hemianopia will be there. Typically there is a lesion of the optic tract, and that is leading to the development of the loss of the vision in both the eyes and in one eye it is affecting nasal and the other eye it is affecting temporal. So which side is the lesion? The side where the temporal is there and the side from where the nasal is coming. Contralateral side nasal and ipsilateral side temporal will be passing to the what? Your optic tract. So that is the reason there is a homonymous hemianopia. One side nasal, other side temporal is the combination which you basically come across. Are we right? One side nasal, one side temporal, doctor, because it is a combination of the two optic tract. That's the reason. Now, what is the common cause for the involvement of the optic tract? Any syphilitic meningitis, or if there is any aneurysm of the superior cerebellar or posterior cerebral arteries, then that leads to development of the optic tract lesions. Now comes our lateral geniculate body, the next station. See, you have two geniculate bodies, medial and lateral geniculate body. Between the two, which is involved with the vision? Lateral. Then medial geniculate body is associated with audition. Superior colliculus is involved with superior colliculus sustadi, inferior colliculus intadi. So that is the reason superior colliculus will see vision, inferior colliculus will be hearing, so audition. So if there is a problem in lateral geniculate body, what will happen, doctor? It will produce homonymous hemianopia, but pupillary reflexes are not affected. Why? Lateral geniculate body, where is it located? Above the level of the pretectal nucleus in the midbrain. In the brainstem, what are the three structures you have? Midbrain, pons, medulla. In the midbrain, you are having typically these pretectal nucleus, colliculi, all these structures are there only. But the level at which the lateral geniculate body is there and pretectal nucleus are there are different. Right? The lateral geniculate body is there at a higher level. Below that only pretectal nucleus is located, where already the pupillary reflexes are carried out, even if lateral geniculate body is affected above the level of the pretectal nucleus. You agree with me? Even a lesion in lateral geniculate body will go back and affect lead to optic atrophy. So this is very important. Every time we are saying it leads to partial optic atrophy. Until which level in the anatomical tract it leads to optic atrophy, you need to remember. Okay. Now, lateral geniculate body ke baad what is there? Optic radiation until it reaches which one? Occipital cortex ka visual cortex. But in its long journey towards occipital cortex, it has to pass through parietal lobe, temporal lobe, and while passing there can be infarct anywhere. So that is the reason anywhere in this optic radiation there can be development of a lesion. Now, what will optic radiation lesions will lead to? They lead to a complete homonymous hemianopia. Suppose if the parietal lobe is involved during the journey of this optic radiation, then what we get is the superior fibers of the optic radiation get affected. And when the superior fibers of the optic radiation are affected, then what we get is called inferior quadrantic hemianopia. Right? So parietal lobe lesions finally lead to inferior quadrantic hemianopia. Then if it is involving temporal lobe contain the inferior fibers of the optic radiation, and hence patients will develop superior quadrantic hemianopia. It's called pie in the sky. It is in the temporal lobe lesions. Now let us look. Where is this hemianopic, homonymous quadrantic hemianopic lesion located? Superior quadrant. So superior quadrant is temporal lobe. Right, doc? Then if you look at this Once more, let us look at pictorially. Optic chiasma, this is the optic tract. They reach the lateral geniculate body from which they have started, and optic radiation is ultimately reaching the visual cortex in the occipital pole. While passing, it has got two loops. So, any of these loops can get affected. So, suppose if Meyer's loop is cut, then the vision will be lost in the upper visual world, in that upper quadrant, right? So, where is the Meyer's loop is basically passing through? It is the temporal lobe, right? So, temporal lobe lesions will lead to superior quadrant anopsia. Parietal lobe lesions lead to inferior quadrant anopsia is what you are going to ultimately remember. Then if the parietal lobe get involved, who will get affected? The lower visual world on one side get affected, and what we get is called inferior quadrant anopsia is what you need to ultimately remember. But in exam hall when we go, we know that temporal lobe lesions lead to superior quadrant anopia, parietal lobe lead to inferior quadrant anopsia. Exam में जाने के बाद ये ऊपर वो नीचे हो जाएगा, right? So how will you remember? Generally the rule is, if you go to PGI, AIMS or anything, you have senior residents, junior residents. Junior resident hota hai gadha, donkey. He has to do all the work. What will senior resident? He will finish MD and he will be preparing for DM. In a night duty, he don't see cases. He will be relaxing. And always, if you ask him to do something, he will have a high temper. So we used to say, senior residents have a high temper. So superior quadrant anopsia is temporal lobe. Inferior quadrant anopsia is parietal lobe. Is what you should not basically forget. Now doctor, if the lesion is involving occipital lobe, when will it occur? It's not very easy to get an occipital lobe infarct unless posterior cerebral artery occlusion if it is there. Then what the people is get is called homonymous hemianopia sparing the macula. Is a lesion which you get if there is any infarct which is involving the occipital lobe. Then one more important thing is, if the parietal lobe is involved, you get an inferior quadrant anopsia. Then when parietal lobe is involved, even other features of parietal lobe lesion will also be there, no? What is the common clinical test we use for parietal lobe? Parietal lobe is important for us for what purpose? Our spatial orientation into this world. You are passing through, you are driving a car. Every time will you check how many centimeters this car is, that car is, this bicycle is. We don't. Involuntarily only we will be knowing how far it is, how fast we can go, when we can apply brake, everything. At least in the initial days we don't know, but later on. Right? All is due to parietal lobe. So if the parietal lobe is affected, other features will be positive. Especially we elicit optokinetic nystagmus in the people who are having a parietal lobe lesion. And always, any lesion at lateral geniculate body or optic radiation or occipital lobe, all of them, whenever they cause blindness or a visual defect, pupillary light reflex won't be affected. Why? Because the pupillary light reflex is mediated at the level of the pretectal nucleus, which is below the level of the lateral geniculate body. That is another important point that we need to fundamentally carry. So why will optic radiations can get affected? Any vascular occlusions, any tumors or a trauma, anything can lead. Then finally when posterior cerebral artery supplying the occipital cortex, if it get affected, then we get homonymous hemianopia sparing the macula, which is congruous. Unlike the earlier we have seen incongruous incongruous. It's not like that. What we get is a congruous homonymous hemianopia. Then why will occipital cortex get affected? One is infarct. Even head injury is another important cause for the development of the occipital lobe involvement. And what will you expect pupil reflexes to be? Anything lateral geniculate body and above, pupil reflexes are normal. And optic atrophy does not occur. Only until the level of lateral geniculate body only retrogradely optic atrophy occur. Above that optic radiation occipital lobe, optic atrophy doesn't occur. So that is all the story that we need to remember. So summarize, doctor. A lesion of the visual cortex will lead to macula sparing congruous homonymous hemianopia. Even in a sleep you have to answer it correctly. Then what else you will remember? If at all there is an involvement of the optic radiation, what will happen? Complete homonymous hemianopia. Sometimes it can be macular sparing. If parietal lobe is involved, superior fibers are affected and inferior quadrant anopsia. There is a confusion. Then if the temporal lobe is involved, then what we get is a superior quadrantic hemianopsia because inferior fibers of the radiation got involved. Then geniculate body, if it is affected, nobody will ask in entrance. Ask your classmates to remember. Because lateral geniculate body lesions lead to what is never an MCQ in the exam. Mainly parietal lobe, temporal lobe, superior, inferior. That is the only thing. Which is macular sparing, macular involving. This is another common confusion. Which is incongruous and congruous hemianopia. And which is bitemporal hemianopia. Only 5 questions, doctor, you need to remember for entrance. But to remember them, you need to pass through all this grass. There's a whole problem. Then, if optic tract is involved, incongruous homonymous hemianopia, you will not forget. Then, if the chiasma is involved, lateral central compression. Lateral compression lead to binasal, and central compression lead to bitemporal hemianopia, like what you classically see in case of the pituitary tumors, is what need to be ultimately remembered. So that brings us more or less to the end, but only discussing hemianopias will make a general medicine teacher still suffer some shortage. What is that? Pupillary problems, abnormalities. Without discussing that, if we leave now, next life will be born as an ant. So that's the reason, let's be very sure. How are the various abnormal pupils? Very simple. You have hemerotic pupil. What is the meaning of it? Hemerotic means your retina is unable to perceive the light. So, suppose if the right eye got affected, generally these things occur, hemerotic pupil occur if there is any lesion in the optic nerve or the retina. Let us say the optic nerve or retina on the right side got affected. What will happen? Direct light reflex will be missing. In which eye? In the affected eye. And when you throw the light, that light should go from that eye only into the other eye and lead to consensual reflex, no? So the other eye ka consensual reflex is gone. Agreed? But if you throw the light into the other eye, its direct reflex is present, and that brings the light and constricts the diseased eye. Got it? Because diseased eye ka sphincter pupilla is working, Edinger-Westphal is working, efferent pathway is working, but afferent pathway is not working. Hence, what do you see in hemerotic pupil? If my right optic nerve or right retina is abnormal, my right direct and left consensual is gone. But if you throw the light into my left eye, the left direct will be there and my right consensual will also be there, is what need to be remembered. No big deal. You know all these things. Then, vernix hemianopic pupil. What does it mean? If the optic tract is involved, Wernicke's hemianopic pupil will be there, wide of there. If you take my right optic tract, what is it carrying? My right-sided temporal fibers and optic tract is between what and what? Between optic chiasma and lateral geniculate body. So it is carrying my right temporal and my left nasal. So in this condition, what will happen if there is a lesion? If you throw light on the temporal half of the retina, because my temporal fibers are carried by my ipsilateral side optic tract only, no? So my temporal field is gone. So if you throw light on my temporal half of the retina on the affected side or the nasal half of the opposite side, eye, then the light reflex will be typically absent. You agree with me? But if you throw light on my nasal, obviously it goes without saying. Why 2 times to repeat? If 2 into 3 is 6, 3 into 2 is also 6, no? So what is my optic tract on the right side is carrying? My right side temporal and left side nasal. So if you throw light on my right side temporal or left side nasal, light reflex won't be there. That is called Wernicke's hemianopic pupil. Simple. If you remember that the lesion in which place? Optic tract is responsible for Wernicke's hemianopic pupil. Then who is Marcus Gunn? Marcus Gunn is a lazy fellow. Suddenly a girl came and gave rose. You are the class topper, I like to fall in love with you, are you ready? If I am class topper, I will get these opportunities regularly, no? So why unnecessarily to commit now only? So he didn't accept the rose at that moment. But next day he discovered that his roommate was offered a rose. Then he said, I will also take the rose. So Marcus Gunn is like that. If you throw the light, what did you expect? Pupil to constrict, right? But it won't constrict at that point. But when you are moving out, then lazily it is constricting. So that is the reason, if there is any relative afferent pupillary defect, it is called as. If any lesion is there in the optic nerve, in those people, when you throw the light, immediately the constriction doesn't occur. When the light is moving away, when you don't expect constriction, that time constriction occurs. That is a problem in case of the Marcus Gunn pupil, which is due to rapid, RAPD, relative afferent pupillary defect, is what need to be remembered. What is paradox about it? When you are throwing light, there is no constriction. When you are moving away, there is a constriction. Which is the paradox about it? Then Argyll-Robertson pupil, all of you know. What is that? Accommodation reflex is present. Light reflex is absent. What is the other name which is being given for this? Prostitute's pupil. Why? A prostitute will accommodate, but she won't react. So that's the reason earlier days. One more reason why they call prostitute pupil is common in the case of the neurosyphilis. Neurosyphilis, that's the reason. And reaction to the near reflex, accommodation reflex is present, but the light reflex is absent, and that's called light near dissociation, which is called as Argyll-Robertson pupil. Another common MCQ asked in the exam is, what will be the size of the pupil in Argyll-Robertson? Normally, if Argyll-Robertson guy is coming to you, hello, he is shaking your hand. You have looked into his pupil, what will you find? Normally, when we are in a daylight, what do we expect? There is some size for the pupil, right? The resting size of the pupil by itself will be small. So what they have is, pupil is The eye which is affected with Argyll-Robertson by naturally is in a small size. That's what you basically discover. Then, how is Addy's pupil? In this, light reflex is absent, just like in Argyll-Robertson. Near reflex is present, but it is very slow and tonic. That is Addy. And unlike Argyll-Robertson pupil, उसमें भी light reflex नहीं है, मगर accommodation है. How will you differentiate? Argyll-Robertson is a small pupil, baseline. Addy's tonic pupil, the affected pupil, is a larger pupil, baseline. So that's how you differentiate. Usually, Addy's is unilateral. Addy's is associated with other neurological things. What is that? Areflexia. Absent knee-jerk reflex will be there. It's more common seen in young women. And how will you diagnose it? Is there any simple test to diagnose it? In the people who have Addy's pupil, fundamentally they have a denervation. Because of the denervation, they have a hypersensitivity of denervation. So in normal people, if you put a weak concentration of meiotic pilocarpine, which is cholinomimetic, it won't constrict. But in these people, due to the denervation hypersensitivity, even a weak pilocarpine drops also will induce meiosis. So what is the other word you will remember? The denervation hypersensitivity of a tonic pupil of the Addy is what you need to remember. So summarize, doctor, these are only 5-6 points which are frequently asked in the entrance, which you need to be very clear. Finally comes cortical blindness. So what is the meaning of it? If somebody had a bilateral occipital lobe lesions, then they develop what is called cortical blindness. Suppose if only one side occipital lobe got affected, will it get affected? You have seen, no? Any stroke involving the posterior cerebral artery can affect the occipital lobe. Unilateral occipital lobe lesions, what will they lead to? A macula sparing congruous homonymous hemianopia, which is contralateral. Whereas for cortical blindness to occur, if there is any embolization to both the posterior cerebral arteries, generally that is responsible for a bilateral vision loss. Okay, that's what we need to appreciate. Now, what are the 3 very important features we need to know about cortical blindness? Suppose if you have a patient, he can have a blindness because of a retina involvement, optic nerve involvement, chiasma involvement, lateral geniculate body involvement, or bilateral cortical involvement. How do you differentiate? First, there is a bilateral vision loss in cortical blindness. Second, the light reflex won't be affected. It will be normal. Then very peculiar feature is, whatever that they dream, those visual images and imagery will become preserved. Can you remember what did you dream yesterday? It's very difficult. Remember the normal life only, to remember faces is difficult nowadays. इसलिए Facebook लगाया. So to remember what is there, the face which I have seen in the dream is much more difficult. Then Anton syndrome, redox phenomena. These are 2 words you need to know about cortical blindness before we say goodbye. What is Anton syndrome? Patients who have cortical blindness, peculiarly they deny that they have blindness. It's called Anton syndrome. Just like those who wrote NEET PG poorly will deny that there is a NEET PG. They'll say state PG was better. So state PG jo likha, they go into which Anton? Who wrote state PG better? They go into NEET PG Anton. NEET PG kabhi bhi nahi hota because I performed state PG better. We need to see what court will say. Now, what is redox phenomena? Typically, they can perceive kinetic but not static targets, which is called redox phenomena in case of bilateral cortical blindness.